Hello, let's talk about hemolytic anemia. Hemolysis actually occurs before the anemia. The anemia is what results if hemolysis outpaces the bone marrow's capacity to replace red cells that are busted open. And so that's the mechanism. Red blood cells are getting popped. And the easiest way to think about hemolysis is by where it's occurring. And there's really two main places hemolysis occurs. You can think about it. Is it inside the bloodstream or is it in the spleen outside of the bloodstream? And that would be an intravascular and an extravascular hemolysis. And the reason you'd want to break it up into those two categories is because there are characteristic lab values for both of those categories that narrow your differential down. So an intravascular hemolysis is going to be less common than an extravascular splenic hemolysis. Whenever you've got an intravascular hemolysis, your blood cells are dying in circulation. So they're popping open and spilling all of their contents into the circulating serum, which includes a lot of hemoglobin. Red blood cells have a lot of that. So the way that you diagnose an intravascular hemolysis is by hemoglobinuria. You're going to see tons of it in the urine, and you would not see that in an extravascular hemolysis in which macrophages of the spleen are sequestering all of the hemoglobin that comes out of lysed red blood cells. So intravascular hemolysis, we have a hemoglobinuria. You're also going to see a low blood haptoglobin. Now, haptoglobin is a protein that's normally pretty high in blood, and it's going to go down whenever you have hemolysis because haptoglobin's role is to complex with iron to get it out of the bloodstream because it's pretty toxic. It generates free radicals via the Fenton reaction with peroxide. So you don't want that iron floating around, and haptoglobin is what uses up itself to sequester it. That's why haptoglobin goes down in an intravascular hemolysis. So that's intravascular hemoglobinuria, low haptoglobin. Now, extravascular hemolysis, well, go back a little bit. What are some causes of intravascular hemolysis? Easy one, macroangiopathic hemolytic anemia is going to be due to aortic valve calcifications. It's a big old valve, and a lot of red blood cells bump up against the aortic valve on their way out of the left ventricle. And so if this aortic valve is stiff and inflexible, it doesn't get out of the way when the blood's coming through. So a lot of blood hits the valve. And that's why you hear a murmur with aortic stenosis, but also that's why you get a hemolysis with aortic stenosis. So the way they'll ask that in a question is they'll give you all the classic findings of a calcified aortic valve. They'll say the patient's got the crescendo decrescendo murmur along with an S4 heart sound and a point of maximal impulse. And you hear radiations up the carotid, and you're going to get the clue that the patient's got the aortic valve problem. And then you'll get a blood workup in a question. It'll say something like patient's got a low mean corpuscular volume of like 74, 75, and that there's also hemoglobin in the urine. And so that's going to be your clue for the hemolysis component of that. And then they can ask you whatever they want about the mechanism. You already know what's going on there. Now, that's macroangiopathic big blood vessel hemolytic anemia. Again, that's intravascular still. And another subdivision of intravascular hemolytic anemia is microangiopathic, which happens in your small vessels, your capillary beds, and your arterioles. And what would cause blood cells to pop in your small vessels? And to me, the most obvious answer is if there's a big old clot in one of those vessels, blood cells not making it past that clot. These blood cells, these red cells are pretty fragile. They just go pop at a whim. And so they bump up against a platelet. If they take a bad hit, that's it. They're done. They can't take anymore. And so what could give you clots in your microcirculation? Well, one example would be DIC, disseminated intravascular coagulation. You've got these platelets everywhere that are cross-linked with fibrin strands, and fibrin to a red blood cell, I mean, that's like me or you running into a steel beam like on a full sprint. So that red blood cell's pretty messed up if it hits a clot in DIC. Same thing with HUS, hemolytic uremic syndrome, and kind of a similar pathology, TTP, thrombotic thrombocytopenic purpura. Those are two platelet abnormalities in which you do get some big significant clots in microvasculature, hence the purpura in both. And so red blood cell again hits the clot. It's like me or you just running into a wall at full sprint. No more red blood cell. Intravascular hemolysis, hemoglobinuria, low haptoglobin. So that's how you take out a red blood cell inside the bloodstream. When we're talking about extravascular hemolysis, understand we're referring to how splenic macrophages sometimes yank red blood cells out of circulation and just pop, take them out. Again, the spleen's the organ responsible for that. And when these macrophages phagocytose a red blood cell, they kind of chew them up. And the red blood cell breaks down into different components, and then the macrophage has to figure out what to do with the skeleton of this red blood cell. And so most of the proteins, the macrophage can break down proteins and get a lot of amino acids out of those and put those back into its own amino acid pool. So that would be like the globin chains of hemoglobin. But then that heme part is pretty tricky to get rid of. You can't just chew up iron, so the macrophage holds on to that, and that's why they're hemosiderin laden. They have a brown pigmentation, the spleen of anyone with the hemolytic anemia. And there's also, besides the iron molecule, there's a protoporphyrin ring, and the macrophage doesn't have an enzyme that can cut that up, and it doesn't have any particular use for it, so it spits this protoporphyrin ring out into the bloodstream, okay? And that protoporphyrin floats around until it gets to the liver. And the liver says, oh, hey, I can do something with you. And it takes that protoporphyrin ring and unfolds it and makes some unconjugated bilirubin. And so the more protoporphyrin, the more hemolysis that you have, the more unconjugated bilirubin you have in the liver. And the liver conjugates that bilirubin to render it water soluble and excrete it out into the GI tract. But if there's more coming in than the liver can push out, you're going to get a backup of unconjugated bilirubin into the bloodstream. And understand, unconjugated bilirubin is not water soluble. It doesn't mix with water. So that's why unconjugated bilirubin deposits all over the body, in tissues, in the sclera of the eye, scleral icterus, and that's typically one of the very first warning signs of a hemolytic anemia is a patient's got jaundice because the unconjugated bilirubinemia. So here's what that looks like, yellowing of the eye, and if you've got a strong, what do they call that? Suspicion, I guess, then you can catch hemolytic anemia before there's even an anemia, because there's going to be hemolysis before there's an anemia. So you would see this jaundice kind of coinciding with the slope of the anemia, the grade of the anemia. Now, the liver takes blood cells out of circulation. That's extravascular hemolysis for a lot of different reasons. And a good way to start thinking about extravascular hemolysis is this immune-based or not? If it's an autoimmunity, you can diagnose that pretty quickly with a direct Coombs test. Let me tell you how. Immune hemolytic anemia definitively means the immune system is popping open red blood cells. Okay, so how could your immune system possibly cause a red blood cell to pop? There's only a couple ways. Number one, it could use complement. That's part of the immune system, right? And you understand that there's complement 1, then 2, then 3 convertase, into 5 convertase, into the membrane attack complex. And that membrane attack complex will poke a hole right into a red blood cell. There's your hemolysis. That's one of 2 ways you can get an immune hemolytic anemia. And as it turns out, complement doesn't just stick to any old cell. It needs kind of a glue to stick it to there. And the glue that sticks complement onto a cell membrane is IgM, which is the first immunoglobulin made by plasma cells. You don't have a class switch out of anything. You're just default IgM. So if you have IgM on the surface of a red blood cell, it can bind complement and activate the whole cascade down through 9, down through the membrane attack complex, and you'll just get an intravascular hemolysis or extravascular from that IgM activating complement. So that's one way the immune system can kill a red blood cell. What's another way? Immunoglobulin G. IgG doesn't do complement. Instead, it's an opsonin. It marks cells for phagocytosis. Now, one component of the complement cascade does the same exact thing. What is that? That's C3b. So if a red blood cell gets stuck with some immunoglobulin or some C3b, if it's just stuck on the surface and the cell can't shake it off, what's going to happen is the next time that red cell goes to the spleen is going to see those opsonins on the surface of the red blood cell, and it's going to say, we got to get you out of here. And it's going to grab it and pop it. No more red blood cell. So that's the second mechanism for how your immune system could cause a red blood cell to pop. And that's really the only 2 ways for an autoimmune hemolytic anemia to work. It's IgM based or it's IgG opsonin based. Now, these are all type 2 hypersensitivities with one big exception. We'll get to that later. Type 2 hypersensitivity is antibody dependent cell cytotoxicity. So again, it's either an IgM that's going to put a hole in the red blood cell, or it's an IgG that's going to tell the spleen macrophages to take that red cell out of circulation. And you're going to diagnose these hemolytic anemias with bilirubin, again, unconjugated bilirubin, but further with the direct Coombs test. Let's go ahead and talk about that Coombs test. The direct Coombs test asks the question, is there any IgG or complement on the surface of this patient's red blood cells? Because again, that's the only way that the immune system could pop a red blood cell, is with immunoglobulin or complement. So the Coombs test puts the patient's blood in a vial and then puts in an antibody against immunoglobulin. So if there's any IgG or IgM in there, or you could use a complement antibody and screen for complement. If there is, those cells are going to stick together. And there's a good graphic here. Let me pull up another simple one. Here you go. In a patient who has red cells with IgG all over the surface, if you put them in a vial and then put it in antibody against IgG, that's called the Coombs reagent, then those cells will agglutinate and you'll see a small little clot at the bottom of the vial. That's a positive direct Coombs test. And all it's asking is, well, okay, patient's got a hemolysis. Is it immune in origin or not? And if it's positive, the answer is yes, it's immune based. Negative means no, nothing to do with the immune system. Work up a different tree. Now, the indirect Coombs test, that's what we use for antibody screens if we have to see titers of something, right? Or maybe we want to check if a patient's got anything before we start a particular therapeutic regimen, or even if we want to screen a pregnant woman for Rh antibodies if she's negative, then we're going to use the indirect Coombs test for that, in which we're taking the patient's serum without the patient's blood cells, and we're putting in some different blood cells, and then we're going to see if they react. So one last time, the direct Coombs test asks, okay, if the patient has a hemolytic anemia, is it because of the immune system? And if it is, then that means by definition, there's immunoglobulin or complement on the surface of red blood cells. So that's all the direct Coombs test does. It looks for complement and immunoglobulin on the surface of red blood cells. And if they're there, it's a positive test. So that's how you work up the autoimmune hemolytic anemias. Talk about them a little bit more. You got warm and you have cold. Now, warm is more common, cold's less common. Warm always involves IgG. So you hear warm autoimmune hemolytic anemia, you think IgG instantaneously. It's nice that they're both so demarcated like this. You hear cold immunohemolytic anemia, you think IgM instantaneously. So there's a sketchy micro for mycoplasma pneumonia, which is the cause of atypical pneumonia. And you know, it's got these, they're playing hockey on an ice pond, and the dude's hitting a puck that looks like a red blood cell, and somewhere in the sketch is a bunch of IgM. So this is what they're referencing. In the case of cold hemolysis, you've got an IgM that sticks to red blood cells only at cold temperatures. And it precipitates at cold temperatures and causes aggregations and clumps of cells. And they clump up in the fingertips because your digital arteries are pretty small and distal. And so that's Raynaud's right there. That's another example of a cold agglutinating disease. And infectious mono is a third source of that. So in my book, that's really all you got to know about it, because not only in a question stem, but in real life, if it's a cold-based hemolytic anemia, the patient will tell you, hey, this gets really worse when I'm cold. This gets so bad when I'm out in the cold. You know, they're going to emphasize it. And same thing for a test question. They will tell you it gets worse in the cold, or they will tell you they found IgM that aggregates at 20 degrees Celsius. And it's like, what more could you want? So mostly this part of the SDL is about the warm antibody disease, warm immunohemolytic anemia. Warm immunohemolytic is the most common cause. Within that most common cause of warm antibody disease is going to be SLE, which is an autoimmunity, and hemolytic anemia. It's another autoimmunity. So if you have SLE, you probably have a certain HLA type that's going to predispose you to developing other autoimmunities. And that's why in lupus, you can see not only hemolytic anemias, but you can see an immune thrombocytopenia. You can see an immune neutropenia. All of the blood lineages in your body are susceptible to autoimmune disease. And that's why it's a diagnostic criteria for diagnosing SLE. Now, the second most common cause of warm immunohemolytic anemia is going to be drugs. And they do like to test about these, and you ought to know about these too, because some of these drugs are pretty common. Penicillin, for example. How many times we use that? So a patient comes in, they took penicillin, and they started taking it this morning, and now it's 6 o'clock at night, and they've got this bad red rash, and they feel like they can't breathe. That's not what we're talking about. That's a type 1 hypersensitivity. It's an anaphylaxis. Type 2 hypersensitivity would be like patients taking penicillin, and then they progressively get weaker and start getting this dyspnea and more fatigue. It's about a week out, and the patient comes to see you and says, man, doc, I feel really bad right now. So you realize they started taking penicillin, you get your CBC, red count is low, you work it up a little farther with the MCV, it's normocytic. What do you want to do next? Unconjugated bilirubin is a pretty good choice. Coombs test after that, there we go. So in penicillin, what happens is that, you know, you take the drug, and this drug gets metabolized by the body. And when it does, a little bit of penicillin actually likes to stick onto the surface of a red cell. So that's not good, because when that red cell floats around, and the next time it goes into the spleen, it's in the red cords. It's surrounded by all these macrophages, which are antigen presenting cells, right? And so the macrophage sees the penicillin on the red blood cell, freaks out and thinks it's a bacteria. So it takes a little bite out of that and goes and gives it to a helper T cell that's going to give it to a B cell. And look at the spleen. I mean, can you see how this happens? It's real easy. All the red cells of the body have to pass through the red pulp of the spleen. And so there's going to be a macrophage that detects the antigen and gives it off to a helper T cell, which is right next to the B cells of these follicles that are characteristic of the spleen. And so the antigen gets passed down the line until the B cell says, oh, I got some work to do. And it starts making antibodies against whatever antigen it just saw. And it puts them straight into the bloodstream. And then those antibodies start sticking onto the red cell with a little piece of penicillin on it, like this here. You know, it's just penicillin stuck to the red cell membrane. And then those antibodies, red cells like, oh man, I'm in for it, because it knows when it gets to the spleen, it's all of a sudden got IgG all over it. And so it's destined for extravascular hemolysis when it does get to the spleen. That's how penicillin can give you hemolytic anemia. And there's also methyl-dopa. Now, that's an antihypertensive drug that we like to give to pregnant women. And same with hydralazine, actually. Hydralazine can also give you a drug-induced lupus. And this is part of why, and the hemolytic anemia component of it. So methyl-dopa it's not like penicillin. In penicillin, you can see the drug actually sticks to the red cell. But in methyl-dopa, the drug doesn't stick, but it plays with your rhesus factor a little bit and gets your body to start making IgG against red cell rhesus factor. So after that point, same exact thing. IgG sticks onto a red cell. The red cell gets to the spleen. That IgG is an opsinin. Macrophages take that red cell up and they dispose of it. Extravascular hemolysis, macrophages spit out the bilirubin. It's insoluble in water, so it accumulates in sclera. So you see sclera lictoris. That's how you know you got a hemolytic anemia. Another drug that can do it, quinidine. It's a class 1C antiarrhythmic. And this one's a little bit different because it's based on IgM, not IgG. And so this is actually going to be a type 3 immune complex hypersensitivity. You ever get asked a question about quinidine and hemolytic anemia, that's a type 3 hypersensitivity. And that's easy to remember because it's the one that's not a type 2 hypersensitivity. Literally every other one that I've seen is a type 2 hypersensitivity. Here's a cool blood smear showing you. Here's a normal red cell over here, or a relatively normal red cell. And these dark, dense, like blood red, wine red cells, these are spherocytes that don't have a lot of cytoplasm because they don't have a lot of membrane. And so sometimes when the spleen goes to take a red cell out of circulation, it misses. The red blood cell gets away. So it's good. It's good. The underdog wins sometimes. And so when it does, it kind of escapes with, only its arm cut off, not its whole body. So it's only a scratch. And so red blood cells out there in the circulation the next time, and it's got less membrane because the spleen took a bite out of it. And so when it's got less membrane, it adapts to spherical conformation because that's an efficient surface area to volume ratio. So those are spherocytes, which are characteristic of hemolytic anemias. And then you're also seeing some reticulocytes here. These are the darker staining cells. They've got a little bit of a bluish purple tint to them. These are reticulocytes in this image. And those reflect that the bone marrow is getting a lot of erythropoietin and is pushing out red cells quickly in a hurry to correct the anemia. So that's what a smear looks like for any autoimmune hemolytic anemia. Let's go through this SDL now. Warm autoimmune hemolytic anemia. You've got IgG destroying red blood cells at a warm body temperature. It is a significant cause of mortality if untreated. The anemia is pretty bad. Again, everything gets hypoxic. It can lead to circulatory collapse. Respiratory failure too, takes a lot of ATP to breathe. Again, warm, 90% cold, 10%. They'll tell you if it's cold. Think warm until proven otherwise. Primary means we have no clue why it's happening, and as you can tell, it's 70% of all cases. Most common cause of secondary, that means we do know why it's happening. Again, SLE. And in fact, one of the diagnostic criteria for SLE is anemia. How do these patients present? What are some more symptoms that they have? Dyspnea at rest, fatigue. That's non-specific for hemolysis. Also, the hyperdynamic state. This is really interesting, actually. Any anemia that you get can put you in the hyperdynamic state, in which blood's a little bit thinner. So when the heart pumps, I mean, that blood just goes like Roadrunner right out of the heart, because it's so lightweight that it's easy. You know, it's like, think about throwing a baseball versus throwing a bowling ball. You know, it's like when you don't have a lot of red cells in the blood's a lot more like a baseball than a bowling ball, a lot easier to throw out of that heart. So that's the hyperdynamic state. You can get those bounding pistol shot pulses and palpitations too, just because the heart doesn't know what to do. There's no blood in it. Like, it gets blood out so easy. And then roaring in the ears, also reflecting a very high cardiac output. And a sign that you're dealing with that is going to be a low hematocrit, or the cellular component of blood. And the reason why you get hyperdynamic is because viscosity is in the denominator of blood flow, Q. And so viscosity is directly proportionate to the concentration of cells, the cellularity of blood. And so the less cellular that it is, the less viscous it is, and thus the higher your flow is going to be if the denominator goes down. What do your labs tell you besides the direct Coombs test being positive? Reticulocytosis, got it. Reduced plasma haptoglobin, got it. Reflects iron in the blood. And of course, your unconjugated bilirubinemia. Talked about this section. You want to treat these patients with glucocorticoids because it is immune-based. And glucocorticoids will shut that immune system down. There are some more aggressive options, such as cyclophosphamide and cyclosporin. I mean, if you really want to shut the immune system totally off, you can do that. So, never know, might need to. Cold antibody hemolytic anemia. Mycoplasma is the definitive example of this. Raynaud's is another one. And presentation is self-explanatory. The patient doesn't get symptoms until they're cold, and then they get a whole lot of symptoms. And the symptoms are very similar to those we just discussed for warm hemolytic anemia. So this one can be post-infectious, just like warm. And you'll see polyclonal antibodies. And I highlight that to say that if it's monoclonal, that's cancer, right? Because that means you got a clonal B cell or plasma cell population making the same exact antibody. Infections that can give you cold agglutinin. Put these in your book. Wherever you take your notes, write them down. Mycoplasma, mono, and Legionella. So don't be surprised if you get a question involving one of those three different pathogens. In the post-infectious cold agglutination, it does tend to be self-resolving within a few months. Now, sometimes lymphomas can give you cold agglutinin disease. The way you'll tell this apart from the post-infectious cold agglutinin disease is going to be the presence of monoclonal antibodies in the setting of a white blood cell cancer. Clinically, one thing to add to the picture of warm hemolytic anemia is going to be this livedo reticularis. And The reason you're going to see this more often in cold agglutination is because cold agglutination, remember, is IgM mediated, and IgM can activate the whole complement cascade. IgG can't do that. IgG sits on the red cell and waits until it gets to the spleen, and that's extravascular hemolysis. But in cold hemolysis, where it's IgM mediated, those red blood cells often get popped right in the bloodstream. And when they do, they can cause inflammation, they'll back up locally along the pathways of your medium and small vessels, leading to this thing called livedo reticularis. You're going to get some obstruction of capillaries due to the agglutination of those red blood cells, and then other red blood cells are going to hit that wall and start to pop. And so there's going to be a lot of deoxygenated hemoglobin floating around, and the tissue's not going to get perfused in these regions, which is going to create discoloration of the skin where this occurs. That's livedo reticularis. You see it in the distal extremities most often. You can also see it in antiphospholipid syndrome. So lacy, it's a real lacy purple rash. And that's cold agglutinin disease. There it is in the text mentioning how cold agglutination does sometimes present with intravascular hemolysis. Getting those reps in, might as well saying the same thing over and over again because it's important. If you see intravascular hemolysis, you've got a low haptoglobin and you've got a hemoglobinuria. Paroxysmal cold hemoglobinuria. The long and short of this one is that it's cold, but it's IgG mediated, so it's got the best of both worlds here. And because it's IgG, well, IgG can weakly activate complement. Not nearly as much as IgM, but it can weakly do so. So if you've got an IgG that is always stuck on every red blood cell that it attaches to, then some of them are going to split apart inside the vasculature. So this paroxysmal cold hemoglobinuria is noteworthy in that it is always, always, always intravascular hemolysis because the immunoglobulin never dissociates from the red blood cell. And you diagnose it based on the Donath-Landsteiner test. Yeah, I got nothing. Okay, back to what we talked about a little bit before. Intravascular hemolytic anemia that has no immune association. If it's in a small blood vessel, it's because of clots. If it's in a big blood vessel, it's probably due to the aortic valve. And then there's this March hemoglobinuria, which when you're running, you're literally stepping on red blood cells. I mean, like, try to act like you're not. You totally are. So if you run enough or you march enough, then you can actually get anemia from that. Transfusion reactions. Okay, these are important. Clinical presentation. It's either acute or delayed. Now, you're going to make the diagnosis of transfusion reaction with a Coombs test because it's going to be an immune-based hemolytic anemia. And remember, the only way your immune system can kill a red blood cell, there's two ways: puts IgM on it and pops a hole, or puts IgG on it and the spleen takes it out. If it's acute, what that really means is that the patient got the wrong bag of blood, because if they were cross-matched properly, typed properly, They should not be getting an acute transfusion reaction. So somebody made a really big mistake if you're seeing chills, fever, hypotension, dark hemoglobinuria, possibly renal failure, very soon after the transfusion. If patient starts developing more mild symptoms of hemolysis, kind of a week, 5 to 10 days after transfusion, that's not the same thing. That means they did get the right blood. They got type blood, cross-matched blood. But thing is, there are so many different antigens on the surface of red blood cells that we really don't have a good feel for every single one of them when it comes to matching people. And even if we did, it would be virtually impossible to match people perfectly for every small little protein or glycoprotein on the surface of their red cells. So what do? We match the big ones that we know are going to cause a reaction if we don't get them right. And then we say, well, the little ones, we did our best, basically. Like our knowledge just hit a wall. So when you get a delayed hemolytic transfusion reaction, that's what's happening there, is that there's a cross reaction and an antibody response to something on the donor cells that this patient got transfused with, but it's not a big enough or significant enough protein to cause a more systemic response and thus an acute reaction. So it's not like a HLA or an ABO mismatch. That'd be really bad, right? ABO mismatch would be like what causes the acute hemolytic reaction. Now, finally, we got this disease called paroxysmal nocturnal hemoglobinuria. And in one sentence, this disease is intrinsic hemolysis. So that means there's a problem with the red cell. And it's intrinsic, there's a problem with it because complement just sits on these red cells and won't move off of it because these cells do not express any surface decay accelerating factor. And decay accelerating factor is essentially an antagonist of complement. It's like a big broom or, a squeeze bottle and sponge, or like a ShamWow that just sits on the surface of a red blood cell. And whenever complement starts to sit on the membrane, DAF just goes, hey, you get off, just scrubs it off, sweeps it off. So that's what decay accelerating factor does. Then if you don't have it, your red cells are susceptible to hemolysis by complement. Okay, so that's the pathology. Why then does it happen at night? That's how these patients present. They wake up and the very first pee that they take in the morning is dark, cola colored, red practically. And then as they go throughout the day, it gets a little bit lighter. By noon, it's about pink. By 3 p.m., it's like a nice tangerine. And maybe by 8 p.m., they're back to nice post-it yellow pee. And by that time, they're like, oh, hey, maybe this is the day that I go to sleep and I wake up and my pee is not red the next morning. It's like, no. Unfortunately, it happens again the next day. The same thing. It's Groundhog Day, but when you pee. So the reason why this happens in the morning is because when you go to sleep, you slow your ventilation and you go into, because of the slow hypoventilation, a respiratory acidosis. Now, this will make a lot of sense to you if you've never heard it already, but systemic acidosis activates complement. It upregulates complement activity. And we want that because there's also acidosis in systemic infections, states of systemic inflammation. So we want complement to be responsive to a low pH. So when you go to sleep, complement goes up. And if you don't have decay accelerating factor, that complement just pops red cells. There's your hemoglobinuria because it's an intravascular hemolysis. Now, sometimes you do see a pancytopenia with this, meaning platelets, white cells, red cells, they're all gone. And the reason why you'd see a pancytopenia is because, well, complement doesn't care. Complement doesn't have eyes even, complement sticks on anything that has a phospholipid bilayer. Actually, it does. So it's not only sticking on your red cells, it's sticking on your platelets, it's sticking on your white cells. Everything that's in the bloodstream, complement's grabbing it and popping it wide open in the middle of the night when you're hypoventilating and acidotic and there's no DAF in your body. All right. This was a busy SDL. That's about all I got for it. Thank you very much for sticking with me.